evening, Google Tamil. So I hope I'm audible. If I'm audible, can I see a thumbs up, please, in the live chat? Okay, I can hear myself. So good evening, all of you. If you're joining the session for the first time, this is Dr. Shanmugapriya. I'm professor and head of the Department of Biochemistry at Government Thoothukudi Medical College. Thank you, Megha. So I'm professor and head of the Department of Biochemistry at Government Thoothukudi Medical College, and I'm your Unacademy educator for biochemistry. And today's session, it's basically a part of 3 hours FMG quick revision series. So there are 2 sessions in this series. One is conducted today, and the next one will be tomorrow at the same time at 5 o'clock. So totally it will be 3 hours session. And in these 3 hours, if you watch these 3 hours video, then you will have a comprehensive idea of biochemistry and you'll be able to answer most of the questions asked in FMG. Okay, so that's a plan for today's and tomorrow's session. And before we start the session, let me tell you a few facts about Unacademy plans. So first about MBBS Prof 1 course, we have just started this Prof 1 course, and in this course, anatomy, physiology and biochemistry, all 3 subjects will be discussed in detail. And all these 3 subjects will be clinically integrated and will be aligned. Guidance will also be given to students about how to approach practicals and viva. So this will be a boon to those who have just joined MBBS. So if you get to know any of you juniors who have just joined MBBS who's looking out for a guidance, you can definitely suggest this course. And 3 months, this course would cost them 5,500. And this is inclusive of 10% discount. To use 10% discount, they can use my code, which is C Shanmugapriya. And now we have on Unacademy light subscription. So light subscription gives you an access to appear for all tests. So there are subject-wise tests, system-wise test, full-length mock test, and grand test. And all plus subscribers, after every plus session, there is also a daily practice paper. So that will help you all understand. If you have plus subscription, if you attend a plus class, then you will be able to understand how much of the concepts you have understood by the end. So that you can rework on those concepts later. Good evening, Shivani. And special class features include interactive live sessions. You'll be able to participate in polls. And if you use the raise a hand option, you'll be able to interact with the educator one-on-one and you can get your doubts clarified real time. And apart from live and recorded free sessions on Unacademy, there are multiple free tests which are happening. This is the free test calendar. Try to attempt as many tests as possible because that will help you understand where you stand. Plus subscription gives you an access to both live and recorded classes. It also gives you an access, good evening Z. It also gives you an access to a question bank with 25,000 plus clinical case-based MCQs. And all these MCQs are framed based on the latest pattern. Iconic subscription, as you all know, gives you an access to not only an Unacademy platform, but also to PrepLadder platform. And if you have either a plus subscription or iconic subscription, then you will be able to access all the structured courses which are planned here. If you're an FMG aspirant, there is an FMG 2022 High Yield Revision and MCQ batch which just started on April 20th. The duration of this course would be 1 month. And in this 1 month, all 19 subjects will be discussed. It will be a high yield revision series, MCQ based revision series, wherein all previous year questions will be discussed. And if you're a NEET PG aspirant, there is a NEET PG 2022 All Educator Revision batch that also started just on April 20th. The duration of that course is also 1 month. Again, all subjects will be discussed in detail. And these are our toppers in the latest FMG December 2021. The highest was 217, closely followed by 209. And this is the current NEET PG subscription plan. So if you want a plus subscription for 2 months, that would cost you 7,650. Iconic subscription for 6 months would cost you 36,000. Light subscription for 2 months would cost you 2,160. So that's all about Unacademy plans. Let's now start discussing few MCQs, few high yield MCQs. Let's try to discuss. So this is the first question for today. The test that is used to detect a reducing substance in the given solution is. Can anybody try answering this? Reducing substance in the given solution. I want all of you to be active in the live chat. Is it Biuret test or Molish test or Benedict's test or benzidine test? What is answer? The answer is Benedict's test. It's a test that is done to detect the presence of a reducing substance in the given solution. Very good, Rishnika, Megha. Biuret test is a test that is done to detect proteins. Yeah, all of you please memorize it. Biuret test is a test that is done to detect proteins in blood. Molish test. What about Molish? It's a group test for carbohydrates, not only a reducing substance. Any carbohydrate will answer Molish test. Benzidine test is a test that is done to detect blood in urine. Yeah, if you want to detect if there is blood in urine, then you can perform benzidine test. So now it's time that you learn about all tests which can be done to detect abnormal constituents in urine. So the first abnormal constituent is, as I told you, you don't have to write it. I will be providing this PDF to you. So listen to this and memorize it. Reducing substance. What is a test done to detect reducing substance, all of you? It is Benedict's test. Okay, that's the first one. Second one is ketone bodies. In FMGE and the NEET PG, ketone body tests are being frequently asked. The test done to detect ketone bodies is Rothera's test. Yeah, have you seen a purple colored ring? Purple colored ring, if that is shown as an image, that is Rothera's test. It's a test that is done to detect ketone bodies. And then to detect if there is protein in urine. What is the test for protein in urine? It is sulfosalicylic acid test. Yeah, protein in urine is sulfosalicylic acid test. And then blood, to detect if there is heme or hemoglobin, or in other words, to detect if there is blood in urine, then we do benzidine test. So don't get confused between Benedict's and benzidine. Benedict's is reducing substance, benzidine is for blood. And then what is the test that is done to detect bile salts? Can anybody answer this? Bile salts. Do you remember playing with an yellow color salt? Yellow color powder, sulfur powder. So bile salts can be detected using a sulfur test or haze test. Yeah, sulfur powder test or haze test is used to detect the presence of bile salts. For bile pigments, yeah, for bile pigments, it is Faucher's test. Very good, Mega. Yes, bile salt, it is haze test. For bile pigment, it is Faucher's test. So let me repeat this. I want all of you to repeat it. What is a test done to detect reducing substance? It is Benedict's test. For ketone bodies, it is Rothera's test, which shows you a purple colored ring. And then to detect if there is protein in urine, it is sulfosalicylic acid test. Blood is benzidine. Yeah, B for B, blood is benzidine test. Bile salt is haze test. Bile pigment is Faucher's test. Okay. So these are the tests that can be asked to you directly as a fact-based question. So the test that is used to detect a reducing substance in the given solution is, what will be the answer? It is Benedict's test. The rate limiting enzyme of glycolysis is, can all of you answer this? The rate limiting enzyme, all previously asked MCQs. Okay. So try to answer this. The rate limiting enzyme of glycolysis is phosphofructokinase 1. So let me tell you about all rate limiting enzymes of carbohydrate metabolism pathways. The first one is glycolysis. Just now I told you for glycolysis it is phosphofructokinase 1. Very good, Mega, Sushmita. Excellent. So all those who are here, please try to be actively participating in the discussion. So gluconeogenesis. Don't you all know that gluconeogenesis is reversal of glycolysis? So to reverse glycolysis, what would be the rate limiting enzyme? Something which reverses phosphofructokinase 1 step. So which enzyme reverses phosphofructokinase 1 step? It is fructose 1,6-bisphosphatase. The rate limiting enzyme of gluconeogenesis is fructose 1,6-bisphosphatase. For glycogen synthesis, it is glycogen synthase. Yeah, for glycogen synthesis, it is glycogen synthase. For glycogenolysis, it is glycogen phosphorylase. I will ask you this again during the same session. All of you please memorize it. What is the rate limiting enzyme of glycogenolysis? It is glycogen phosphorylase. And then for HMP shunt, it is glucose 6-phosphate dehydrogenase. So tell me, what are the rate limiting enzymes I've told you about? There is no shortcut for memory. It is just repetition. So whenever I repeat it, it is for your sake. Please repeat it along with me. For glycolysis, it is phosphofructokinase 1. For gluconeogenesis, you have to reverse phosphofructokinase 1. So it is fructose 1,6-bisphosphatase. For glycogen synthesis, it is glycogen synthase. For glycogenolysis, it is glycogen phosphorylase. And finally, for HM patient, it is glucose 6-phosphate dehydrogenase. Okay. So what is answer? The rate limiting enzyme of glycolysis is choice A, phosphofructokinase 1. Products of aerobic glycolysis is, I will wait for you all to answer. What are the products of aerobic glycolysis? Do you get pyruvate? Do you get 2 ATPs, lactate, 32 ATPs? What do you think is the right answer? For aerobic glycolysis, the products formed are 2 molecules of pyruvate. Yes, Megha is right. Sushmita has answered it as choice C. Choice C, lactate is a product of anaerobic glycolysis. The question is aerobic glycolysis. So aerobic glycolysis gives you 2 pyruvate and 7 ATPs. Okay. So let's try to fill up this tabular column. What are the products of aerobic glycolysis? As and when I tell you, please memorize it. Products of aerobic glycolysis will be 2 pyruvate and 7 ATPs. Whereas products of anaerobic glycolysis will be 2 lactate and 2 ATPs. Okay, 2 pyruvate and 7 ATPs for aerobic glycolysis, 2 lactate and 2 ATPs for anaerobic glycolysis. So now I'm going to tell you about choices of fuels. Based on this, can you tell me what is the advantage or what is the significance of glycolysis? Can anybody answer this? Based on these two facts, tell me what is the significance of glycolysis? Significance of glycolysis is that it is the only pathway that can generate ATP even in the absence of oxygen. We all understand this. It's the only pathway which can generate ATP even in the absence of oxygen. So this tells you about choices of fuels. First, tell me why will you want a pathway which can generate ATP in the absence of oxygen? Because we have some anaerobic cells. What are the anaerobic cells? RBCs, right? Retinal cells, corneal cells. Yeah, RBCs, retinal cells, corneal cells. All these cells do not have mitochondria. So all these cells are dependent on a pathway which can generate ATP in the absence of oxygen. So for which cell is anaerobic glycolysis indispensable? RBCs, retinal cells and corneal cells. So this will help you in understanding about choices of fuels. Okay. So when I ask you what would be the choice of a fuel, I've seen that question multiple times in FMGE asking choices of fuels. So whenever the question is on choice of fuel, you try to find out whether the cell is aerobic or anaerobic. If the cell is anaerobic, does the cell have any choice? The only pathway which can generate ATP anaerobically is glycolysis. So if it is an anaerobic cell, then no other go, what should it use as its fuel? It has to use only glucose as its fuel. Okay, whereas if it is aerobic cell can have two choices. Aerobic cell can either utilize glucose or it can utilize fatty acid. But if I give you a choice, what will you choose? I'm giving you a choice. I'm giving you both glucose and fatty acid. I'm asking you to choose one fuel. What will you choose? A cell would choose only fatty acids because fatty acids on oxidation will provide more number of ATPs than glucose on oxidation. Yeah, for example, all of you memorize it. Palmitic acid on complete oxidation. Yeah, palmitic acid on complete oxidation gives you 106 ATPs. There is glucose on complete oxidation. Very good, Menaka. There is glucose on complete oxidation gives you only 32 ATPs. So if I give you a choice, what will you choose? You will choose only fatty acids. That's why all aerobic cells utilize fatty acid as their fuel, whereas all anaerobic cells will use glucose as their fuel. Now, what are the examples of anaerobic cells? Just now I told you, RBCs, retinal cells, corneal cells. Okay, so RBCs, retinal cells, corneal cells, because they are all anaerobic, no other go, they utilize only glucose as their fuel. Similarly, white muscle fibers. Why are white muscle fibers white? Because they don't have myoglobin. All of you listen to this. Red muscle fibers are red because they have myoglobin. White muscle fibers do not have myoglobin. So when they don't have myoglobin, which is a storage form of oxygen, Yeah, they don't have a storage form of oxygen. So what metabolism will they undergo? Anaerobic metabolism. So white muscle fibers are also dependent on glucose. And that is why white muscle fibers store glucose as glycogen. Do you all understand this? White muscle fibers store glucose as glycogen because their preferred fuel is glucose. And then renal medulla. Yeah, renal medulla receives a very less blood supply. Less blood supply is equated as less oxygen source. So renal medulla is also dependent on glucose as the fuel. So can you all tell me what are the cells which are dependent on glucose as their fuel? Number one, RBCs, two, retinal cells, corneal cells. RBCs, retinal cells, corneal cells because they don't have mitochondria. White muscle fibers because they don't have myoglobin. And finally, renal medulla which receives very less blood supply. On the contrary, all aerobic cells, what would be the best example for aerobic cell? It is cardiac muscle fibers. Do you all know that cardiac muscle fibers are known for their mitochondrial content? Yeah, cardiac muscle fibers are known for their mitochondrial content. Numerous mitochondria, they utilize only aerobic metabolism. When it is aerobic metabolism, they prefer to utilize fatty acid as their fuel. And that is why the preferred fuel for cardiac muscle fiber is fatty acid. Similarly, red muscle fiber. Why is red muscle fiber red? Because it has got myoglobin, which is a storage form of oxygen. So it has got an oxygen source, so that undergoes aerobic metabolism. For both these cells, what is the preferred fuel? It is fatty acid, which is the preferred fuel. And that is why red muscle fibers store fatty acid in the form of triacylglycerol and cholesterol ester. Yeah, what does white muscle fiber store? White muscle fiber stores glycogen. Red muscle fiber store triacylglycerol and cholesterol ester. But there is an exception to this rule. When I say all aerobic cells use only fatty acid as their fuel, there is an exception. The exception is neurons. Will you all agree with me if I say neurons are aerobic? Yes, right. Neurons have mitochondria. Neurons have a blood supply. So neurons are aerobic. Though they are aerobic, neurons do not utilize fatty acid. They use only glucose. So can you tell me why is neuron dependent on glucose? Neuron is dependent on glucose because most of the neurons are surrounded by blood-brain barrier. And across the blood-brain barrier, can fatty acids cross? Do you think across? Very good. Renal medulla is a good answer, Menaka, but it's anaerobic because it receives less blood supply. Okay. So neurons, though aerobic, they utilize glucose as their fuel because most of the neurons are surrounded by blood-brain barrier across which fatty acids cannot cross. Yeah, so for a very long time, neurons did not have an access to fatty acid. That is why neurons' metabolic pathway has been evolved in such a way that neurons, though they are aerobic, they use only glucose. So tell me, what is the difference between RBCs using glucose and neurons using glucose? Both RBCs and neurons use glucose. RBCs use glucose anaerobically. Neurons use glucose aerobically. Clear? So this will help you in answering an MCQ wherein they give you a cell's name and they ask you what is the choice of the fuel. Okay. So tell me, what are the cells which are dependent on anaerobic glycolysis? Cells which are dependent on anaerobic glycolysis will include RBCs, retinal cells, corneal cells, white muscle fibers and renal medulla. Whereas which cell is dependent on aerobic glycolysis? It is neurons. Neurons are dependent on aerobic glycolysis. Okay. So can we now memorize energetics? Because I know you're all interested in memorizing facts. Yeah. So let me tell you all facts related to energetics. I want all of you to be very active now. Very good, Menaka. Good. So only Menaka keeps answering. Can I see all others answering, please? So the first pathway about which you have to know is aerobic glycolysis. So what do I mean by aerobic glycolysis? Aerobic glycolysis is nothing but glucose getting split into two molecules of pyruvate. Do you all understand this? What is aerobic glycolysis? It is nothing but one molecule of glucose being split into two molecules of pyruvate. And that will give you how many ATPs? Aerobic glycolysis gives you 7 ATPs. Whereas anaerobic glycolysis, all of you tell me what is anaerobic glycolysis? Glucose being split into 2 lactate. Yeah, glucose being split into 2 lactate is anaerobic glycolysis. That will give you 2 ATPs. Okay. Now from aerobic glycolysis, you have pyruvate. What is the fate of pyruvate? Every pyruvate will be acted upon by PDH complex. Every pyruvate is acted upon by PDH complex and it is converted to acetyl-CoA. What is the enzyme? All of you please memorize it. Pyruvate dehydrogenase complex converts pyruvate into acetyl-CoA. And this will give you 1 NADH. And 1 NADH is equivalent to 2.5 ATPs. Is that clear? 1 NADH is equivalent to 2.5 ATPs. This is called as a link reaction. Can anybody tell me why am I calling it as a link reaction? Why is it called as a link reaction? Because this is a step wherein you're going to link glycolysis with citric acid cycle. Do you all understand this? So what is the fate of glucose which gets into any cell? Any glucose goes through glycolysis. All of you try to understand this. Every glucose goes through glycolysis and it gets converted to 2 molecules of pyruvate. This is glycolysis. And then citric acid cycle starts with acetyl-CoA. In citric acid cycle, you start with acetyl-CoA, which gets into citric acid cycle, comes out as carbon dioxide. So what is the link that you should connect? Yeah, the link is you have to convert pyruvate into acetyl-CoA. How can you convert pyruvate into acetyl-CoA? That is done by PDH complex. So PDH complex converts pyruvate into acetyl-CoA and this PDH complex gives you 1 NADH equivalent to how many ATPs? 2.5 ATPs. Is that clear? So this is what I was trying to fill up here. So tell me PDH complex gives you how many ATPs? PDH complex gives you 2.5 ATPs for every pyruvate. And then citric acid cycle. How many ATPs do you get from citric acid cycle? 10 ATPs. For every acetyl-CoA that gets into citric acid cycle. For every acetyl-CoA that gets into citric acid cycle, you get 10 ATPs. So how many ATPs do you get from complete oxidation of one molecule of glucose? How many ATPs do you get from complete oxidation of one molecule of glucose? What do I mean by complete oxidation of glucose? As I told you, you start with glucose. One molecule of glucose gets converted to 2 molecules of pyruvate. This will give you how many ATPs? I'm going to tell you the number. Please listen to this. This gives you 7 ATPs. And then every pyruvate gets converted to acetyl-CoA. And for every conversion, you get 1 NADH equivalent to 2.5 ATPs. So 2 NADH will give you 5 ATPs. So 7 plus 5 is 12. And then every acetyl-CoA gets into citric acid cycle. And every citric acid cycle gives you 10 ATPs. So from 2 acetyl-CoA, you get 20 ATPs. So can you add all these together? 20 plus 5 is 25 plus 7 is 32. Yeah, totally it is 32. That is why this number is essential. It is essential that you memorize this number. The number of ATPs that you get from complete oxidation of one molecule of glucose is 32 ATPs. Why am I calling it as complete oxidation? Because when anything gets into citric acid cycle, it comes out as carbon dioxide. When anything gets into citric acid cycle, it comes out as carbon dioxide, which can be exhaled out. So this is called as complete oxidation that gives you 32 ATPs from every molecule of glucose. I hope it's clear. Yes, it's clear, all of you. If it's clear, can I see a thumbs up, please? So that's about complete oxidation. And then about glycogen synthesis. Okay, so we have filled up till this. Complete oxidation of one molecule of glucose gives you 32 ATPs. Now glycogen synthesis. In glycogen synthesis, for you to add every molecule of glucose, for you to add every molecule of glucose to growing glycogen, you use 3 high energy phosphates. All of you memorize it. In glycogen synthesis, for you to add every molecule of glucose to the growing glycogen, you use 3 high energy phosphates. Okay. And then about gluconeogenesis. After glycogen synthesis, it is gluconeogenesis. What is gluconeogenesis? It is reversal of glycolysis. So in glycolysis, if you split one molecule of glucose to form two molecules of pyruvate, in gluconeogenesis, you will start with two molecules of pyruvate, you will end with one molecule of glucose. And for the conversion of two molecules of pyruvate to one molecule of glucose, you will need 11 high energy phosphates. Do you all understand this? In gluconeogenesis, to convert two molecules of pyruvate to one molecule of glucose, you will need 11 high energy phosphates. Okay. And then as I told you, palmitic acid on complete oxidation. Yeah, palmitic acid on complete oxidation gives you how many ATPs? As everybody should know by heart. Palmitic acid gives you 106 ATPs. Whereas stearic acid on complete oxidation, very good Rishnika. Stearic acid on complete oxidation gives you 120 ATPs. Palmitic acid has got 16 carbon atoms. Stearic acid has got 18 carbon atoms. So stearic acid on complete oxidation gives you 120 ATPs. The last one that can be asked to you is about protein synthesis. It is not 146, 106 and 120. Okay. And then about protein synthesis. In protein synthesis, for you to attach every amino acid, to a growing polypeptide chain, you invest 4 high energy phosphates. Yeah, for glycogen synthesis, for you to attach every glucose, you use 3 high energy phosphates. In protein synthesis, for attaching every amino acid, you will have to invest 4 high energy phosphates. Is that clear to all of you? Have you memorized all these numbers? Yeah. So aerobic glycolysis, it is 7. Anaerobic glycolysis, it is 2. Link reaction. What is link reaction? Pyruvate getting converted to acetyl-CoA is link reaction. That will give you 1 NADH equivalent to 2.5 ATPs. Every citric acid cycle gives you how many ATPs? 10 ATPs. Complete oxidation of one molecule of glucose gives you 32 ATPs. Glycogen synthesis, for attaching every glucose, you invest 3 high energy phosphates. Gluconeogenesis, to convert two molecules of pyruvate to one molecule of glucose, you invest 11 high energy phosphates. Palmitic acid on complete oxidation gives you 106 ATPs. Stearic acid on complete oxidation gives you 120 ATPs. And finally, protein synthesis, for you to attach every amino acid to a growing polypeptide chain, you need 4 high energy phosphates. Okay. So what is the answer now? Products of aerobic glycolysis would be 2 pyruvate and 7 ATPs. Enolase is inhibited by. Can anybody answer this question? Enolase is inhibited by fluoride, fluoroacetate, iodoacetate, arsenate. Very good, Menaka. Yes, enolase is inhibited by fluoride. Okay. So now I'm going to tell you about all inhibitors. So fluoroacetate inhibits aconitase. Yeah, fluoroacetate inhibits aconitase. Iodoacetate inhibits glyceraldehyde 3-phosphate dehydrogenase enzyme. Very good, lazy trip. You're right. So iodoacetate inhibits glyceraldehyde 3-phosphate dehydrogenase of glycolysis. And then arsenate. Do you see arsenate ending with ATE? It ends with ATE, right? So it inhibits another ATE. What is it? It is phosphoglycerate kinase. Yeah, arsenate inhibits phosphoglycerate kinase. So now I will tell you about all inhibitors. I'm going to fill up this tabular column. In glycolysis, there are 3 inhibitors. PDH complex is inhibited by 1 chemical inhibitor, and then in citric acid cycle, we have 3 inhibitors. So yeah, good afternoon, buds. So if you read it all by yourself, it take a very long time to comprehend it. So listen to this and memorize it. So the first enzyme of glycolysis that can be inhibited is glyceraldehyde 3-phosphate dehydrogenase. What is the first enzyme? It is glyceraldehyde 3-phosphate dehydrogenase, which is inhibited by iodoacetate. Yeah, memorize it. It's inhibited by iodoacetate. And then we have phosphoglycerate kinase. What is it? It is phosphoglycerate kinase, which ends with ATE. That is a clue that is given to you, that it is inhibited by another ATE. What is it? It is arsenate. Yeah, phosphoglycerate kinase is inhibited by arsenate. And this is frequently asked, enolase. I will tell you why this is frequently asked in the next question. For now, enolase, an enzyme of glycolysis, is inhibited by fluoride. Yeah, enolase, an enzyme of glycolysis, is inhibited by fluoride. Now, what is the link reaction I told you? Link reaction is nothing but it is catalyzed by PDH complex, which converts pyruvate into acetyl-CoA. And this PDH complex is inhibited by arsenite. Do you understand the difference? Phosphoglycerate kinase is inhibited by arsenate. Pyruvate dehydrogenase complex is inhibited by arsenite. Okay. Now, in citric acid cycle, aconitase. The first enzyme is aconitase. Do you see AC here? Yeah, it is inhibited by, very good. Yes, lazy trip, you're right. It is inhibited by fluoroacetate. Yeah, aconitase, that is AC. It is inhibited by fluoroacetate. And then alpha ketoglutarate dehydrogenase. Alpha ketoglutarate dehydrogenase. So anything that you learn about PDH complex is applicable for alpha ketoglutarate dehydrogenase complex as well. Both these enzymes are very similar. For example, PDH complex converts pyruvate into acetyl-CoA, whereas alpha ketoglutarate dehydrogenase complex converts alpha ketoglutarate into succinyl-CoA. So everything is similar, which means alpha ketoglutarate dehydrogenase is also inhibited by what? All of you answer this. It is also inhibited by arsenite. Okay. And the last one is succinate dehydrogenase. Succinate dehydrogenase is inhibited by malonate. Succinate dehydrogenase is inhibited by malonate. So these are the inhibitors that you should have by heart. Yeah, essential. These are facts that can be straight away asked in FMG or NEET PG or whatever exam you're trying to attend. Okay. So glycolysis, glyceraldehyde 3-phosphate dehydrogenase is inhibited by iodoacetate. Phosphoglycerate, ATE, phosphoglycerate kinase is inhibited by arsenate. And then enolase, the most commonly asked question is enolase. Enolase is inhibited by fluoride. And then PDH complex and alpha ketoglutarate dehydrogenase complex, both these are inhibited by arsenite. And then aconitase. Aconitase has got AC. It is inhibited by fluoroacetate. And finally, succinate dehydrogenase, which is nothing but complex 2 of electron transport chain, and that is inhibited by malonate. Succinate dehydrogenase is inhibited by malonate. Okay. So this is the filled tabular column that you can get in the PDF. You can use this for revising. So answer this. Enolase is inhibited by what? Enolase is inhibited by fluoride. The additive that is used in the given blood collection tube is, how many of you have seen this question? All of you please go through all previous year questions. The additive that is used in the given blood collection tube is, yeah, do you see a red top here? What color lid does it have? It has got a red top. If you see a red top, I want you to remember a mnemonic. The mnemonic is RSS. What does RSS stand for here? The first R stands for the lid. The lid is red color. Yeah, the second S stands for serum. Yeah, red color tube is used for serum collection. And what does it have? It has got silica. So what do you know about red top tube? Red top tube is RSS. What does RSS stand for? Red stands for serum collection. Red stands for serum collection. And here you use silica as the additive. Silica is used as the additive. So why do we add silica? Because silica is a clot activator. All of you just remember this. Silica is a clot activator. Why do we use a clot activator? What is a serum? You collect blood sample in a tube. Yeah, you collect blood sample in a tube. The negative charges of the tube will stimulate in vitro clotting. The negative charges of the tube will stimulate in vitro clotting. After in vitro clotting, what separates above is called the serum. So serum is something which is separated after clotting. So if you just like that collect blood sample in a simple tube, if you allow it to clot, it will take a very long time, which means sample analysis will be delayed. We don't want to delay the sample analysis. That is why what do? We take a tube, we add silica, and into the silica, when you add the blood sample, the in vitro clotting process is quickened. So clotting happens quickly and serum separates quickly so that you can analyze it quickly. That is why silica. Is that clear? So red top tube, RSS, red is for serum separation. It has got silica as a clot activator. Is that clear? Now, what are the other tubes that you can be asked about? So have you seen this tube? What color lid does it have? Do you see a gray top here? Yeah, gray top starts with which letter? G. That is a clue that is given to you, that is used for glucose estimation. It is used for glucose estimation. So gray top tube is used for glucose estimation because it has got sodium fluoride and potassium oxalate. What is the additive that is used in a gray top tube? It has got sodium fluoride and potassium oxalate. So what did I tell you about fluoride in the previous question? I said fluoride inhibits enolase, right? I said it inhibits enolase of glycolysis. So when you collect a blood sample in this tube there is fluoride which inhibits enolase of glycolysis of RBCs. So RBCs are not allowed to use glucose. If you allow RBCs to use glucose, then when you estimate glucose, that will be a false low value. To avoid getting false low value, you collect blood sample in a tube which has got sodium fluoride and potassium oxalate. Fluoride inhibits enolase of RBC. So RBCs are not allowed to use glucose. So that when you estimate glucose, it will be a true value. Clear? So gray for glucose. Have you seen this tube? This everybody must have seen. Lavender topped tube. Yeah, what lid is it? This is a lavender top tube, and it has got potassium EDTA, K2 EDTA. Yeah, lavender top tube has got K2 EDTA, and what is this K2 EDTA used for? This is used for complete blood count. Do you remember collecting blood sample in K2 EDTA tube and sending it to the pathology laboratory when you get complete blood count values? So K2 EDTA is used for complete blood count. It is also used for HbA1c estimation. Yeah, glycated hemoglobin estimation. What should you use? You should only a lavender top tube which has got K2 EDTA. Okay. And then this one, this is a blue top tube. Royal blue is what they call it as. It's a royal blue tube. And this has got citrate, is CBC. You're right, Menaka. So royal blue tube is a citrated tube. Okay, C for C, citrated tubes are used for coagulation assays. PT, APTT, yeah, prothrombin time, activated partial thromboplastin time. So all these coagulation assays can be estimated in a citrated tube, and the citrated tube will have a royal blue top. Okay. So these are the blood collection tubes that can be asked to you as image-based question or as a fact question. So this is a quick recap for all of you. I want all of you to be active in the chat box. Look at the image and tell me red top tube. What is the mnemonic I gave you for red top tube? RSS. So what is this used for? This is used for serum separation. And what is the additive that is present in the red top tube? It is silica. Yeah, RSS. And what is it? What color is it? Gray top tube. Very good. Gray top tube, G for G. It is for glucose estimation. And why do you use it for glucose estimation? What does it have as an additive? It is sodium fluoride and potassium oxalate. I'm happy that all of you are answering it correct. Good Rishnika, good lazy trip. And the next one is this lavender top tube. You send it to the pathology laboratory. So lavender top tube has got K2 EDTA, and this is used for complete blood count as well as for HbA1c estimation. And then this is a blue top tube. What did I tell you about blue top tube? It is a citrated tube which is used for coagulation assays. Okay. So answer this quickly. The additive that is used in the given blood collection tube is, it is silica. Royal blue tube, no. No, Pragya. No. It is, blue has got citrate and it can be used for coagulation assays. So which of the following enzymes is defective in von Gierke's disease? And this is an FMGE June 2020 question. Can you answer this? Von Gierke's disease, which enzyme is defective? The enzyme that is defective in von Gierke's is glucose 6-phosphatase. Ajit Kumar, it is not phosphate dehydrogenase. I know many of you get confused here. So all of you listen to this. Glucose 6-phosphate dehydrogenase is an enzyme of HMP shunt. And when HMP shunt is defective, what is that you won't get? You won't get NADPH, and that presents as hemolytic anemia. Have you all understood this? Glucose 6-phosphate dehydrogenase deficiency or a defect of HMP shunt will present as hemolytic anemia. Whereas von Gierke's is glucose 6-phosphatase defect. Okay. So now I'm going to tell you all about glycogen storage disorders, types and names and the enzyme defect because this is being frequently asked. It is just a factual question for now. In the next question, I will teach you concepts. Okay, so all of you listen to this. So type 1, what is the name? 1 von. Yeah, 1 von. So what is 1? Von Gierke's disease. Type 1 is von Gierke's disease, wherein the enzyme which is defective is glucose 6-phosphatase. And if you're asking me what is glucose 6-phosphatase, it's an enzyme of gluconeogenesis and glycogenolysis. To increase plasma glucose, you need glucose 6-phosphatase through glycogenolysis and gluconeogenesis. Okay. Now type 2. Type 2 is Pompey's disease. Yeah, what is type 2? It is Pompey's disease, wherein the enzyme which is defective is acid maltase. Type 2, the enzyme which is defective is acid maltase or alpha glucosidase. Pompey's is acid maltase or alpha glucosidase defect. Now type 3. Can anybody tell me which is the third alphabet? The third alphabet is C. And what is type 3? Type 3 is Cory's disease. Do you all understand this? Type 3 is Cory's disease. And the enzyme which is defective is after C, you can have D. Yeah, after C, the alphabet is D. So Cory's disease is caused by a defect of D branching enzyme. Okay, type 3 is Cory's disease caused by a defect of D branching enzyme. And then we have type 4. Type 4 is Anderson. Yeah, type 4 is Anderson's disease. After A, the alphabet is B. So Anderson's disease is caused by a defect of branching enzyme. And if you're asking me what is debranching enzyme and what is branching enzyme, debranching enzyme, as the name suggests, breaks something. What is breaking? It is glycogenolysis. Debranching enzyme is an enzyme of glycogenolysis. Whereas branching enzyme is you're forming a branch. That is an enzyme of glycogen synthesis. Debranching enzyme is glycogenolysis. Branching enzyme is glycogen synthesis. Okay. Type 5 is McArdle's. Yeah, type 5 is McArdle's disease. M for M. Tell me what is M for M? M is muscle glycogen phosphorylase defect. McArdle's is muscle glycogen phosphorylase defect. And type 6 is, yes, alpha 1,6 linkage is very good, lazy trip. Type 6 is Hirsch's disease. Yeah, Hirsch's, H for H. It is caused by a defect of hepatic phosphorylase. It is caused by a defect of hepatic phosphorylase enzyme. And then type 7 is Tarrow's disease. And Tarrow's disease is caused by a defect of phosphofructokinase 1. What is phosphofructokinase 1? It is the rate limiting enzyme of glycolysis. So type 7 is Tarrow's disease caused by a defect of phosphofructokinase 1. So have you memorized all these 7 types? If you know these 7 types, that's more than enough as far as FMG is concerned. Okay, so tell me what is type 1, all of you. Yeah, so this is the tabular column. So what is type 1? 1 gear keys caused by a defect of glucose 6-phosphatase. This repetition is for your sake. If you don't repeat, you won't be able to memorize it. Don't think after the session I'll sit and memorize. That will never happen. So by the end of the session, you should remember all these facts and you should understand all these concepts. That's my aim. Okay. So glucose 6-phosphatase is an enzyme which can increase plasma glucose by both glycogenolysis and by gluconeogenesis. Type 2 is Pompey's disease caused by a defect of acid maltase or alpha glucosidase. It was asked once in FMGE, which glycogen storage disorder is a lysosomal storage disorder? It is Pompey's. Yeah, so tell me about Pompey's. This is the only glycogen storage disorder, which is also a lysosomal storage disorder because acid maltase is an enzyme of lysosomes. Type 3, how will you remember what is type 3? The third alphabet is C. So type 3 is Cory's disease. C is followed by D. Cory's disease is caused by a defect of D branching enzyme, which is an enzyme of glycogenolysis. Type 4 is Anderson's disease. A is to be followed by D. Anderson's disease is caused by a defect of branching enzyme, which is an enzyme of glycogen synthesis. Type 5 is McArdle's, M for M, muscle phosphorylase defect. Type 6 is Hers, H for H, hepatic phosphorylase defect. Type 7 is Taruv's disease, wherein the enzyme that is defective is phosphofructokinase 1, the rate limiting enzyme of glycolysis. So have you memorized all these facts? Yeah. So which of the following enzymes is defective in von Gierke's disease? It is glucose 6-phosphatase. Don't say it is glucose 6-phosphate dehydrogenase. Okay. Now this is another question which was asked the next year. The previous question was June 2020 question. This is June 2021 question. Do you see the difference in the way question is being asked? Yeah, previously till some time back it was factual question which was expected always in FMGE. But later development, the latest development is they've started asking you conceptual questions. Okay, this is an example. So 8-month-old infant presents with hypoglycemia. On examination, hepatomegaly was observed. Blood investigations revealed lactic acidosis, ketosis and xanthomas on the buttocks. What is the most probable deficiency? Very good, Vishal. Very good, Menaka Devi. Yes. So what is the principal presenting feature? Whenever you're given a history, do not jump to an answer. Okay. Try to exclude choices one by one. So the principal feature is hypoglycemia. In that case, do you think choice A or branching enzyme defect can cause hypoglycemia? What did I tell you about branching enzyme? It is an enzyme involved in glycogen synthesis. Yeah, you're not using glucose. Glycogen synthesis using glucose. When that pathway is defective, will there be hypoglycemia? No, right? You're not using glucose. If at all there is a defect, it is going to cause only hyperglycemia. Do you understand this? So definitely branching enzyme defect will not cause hypoglycemia. Can it be glycogen synthase defect? Again, glycogen synthase is an enzyme of glycogen synthesis. You're not using glucose. When you're not using glucose, there can be only hyperglycemia. It is not going to cause hypoglycemia. So you have excluded choice A and choice B purely based on the symptom, which is hypoglycemia. Okay. Now, can it be acid maltase defect? What is this condition called as? Can you all type it in the chat box? Acid maltase defect causes what? That is Pompey's disease. Okay, and what did I tell you about Pompey's disease? I said Pompey's disease is the only glycogen storage disorder, which is also a lysosomal storage disorder. The enzyme is acid maltase, and this enzyme is concerned with metabolizing 2% of glycogen in all cells. It is concerned with metabolizing 2% of glycogen in all cells wherein glycogen is stored. So can you tell me what are the cells wherein glycogen is stored? Please answer this. There are only two types of cells wherein glycogen is stored. One is skeletal muscle, cardiac muscle and liver. Don't you all know this? Glycogen is stored in skeletal muscle, cardiac muscle and liver. In all these tissues, the 2% of glycogen is getting affected. 2% glycogen metabolism is getting affected. So when cardiac muscle is not able to metabolize glycogen, that causes cardiomegaly. Yeah, that causes cardiomegaly. So all of you tell me, what will be the presenting feature of Pompey's? Pompey's will present with cardiomegaly and cardiomyopathy, because in cardiac muscle fibers, glycogen is getting stored, it is not getting utilized. When skeletal muscle is not able to metabolize its glycogen, that will cause hypotonia. Yeah, that will cause hypotonia, and that presents with respiratory difficulties, because skeletal muscle, your diaphragm is a skeletal muscle that helps in respiration. So when skeletal muscle metabolism gets affected, that will present as respiratory difficulties and failure to thrive. And because there is hypotonia, the child will present as a floppy baby. Yeah, the child will present as what? Because of this hypotonia, the child will present as floppy baby. So if the history says a glycogen storage disorder, child is presenting with a glycogen storage disorder, there is floppy baby, there is hypotonia, there is cardiomegaly, cardiomyopathy, then what will be our answer? It is Pompey's disease. Okay. And luckily there is enzyme replacement therapy that is available for Pompey's disease. That is why you should pick this up earlier. Yeah, because enzyme replacement therapy is available. The moment you see a child with Pompey's disease, you as a clinician should be able to identify it. That is why I'm telling you in detail about Pompey's disease. Okay. So what are the facts that I've told you about Pompey's disease? Pompey's disease is which type? Type 2 glycogen storage disorder, wherein the enzyme that is defective is acid maltase or alpha glucosidase. It presents with cardiomegaly, cardiomyopathy, hypotonia, floppy baby. Clear? So do you think this will fit into a diagnosis of acid maltase deficiency? Definitely not, because it is hypoglycemia. Okay. So what are you left with? After you have excluded choice A, B and C, what are you left with? You're left with choice D, which is glucose 6-phosphatase deficiency. And what is glucose 6-phosphatase deficiency? It is von Gierke's disease. Okay. When glucose 6-phosphatase is defective, neither glycogenolysis nor gluconeogenesis can increase plasma glucose. So the child will present with hypoglycemia. Von Gierke's disease child will always present with hypoglycemia. And not only hypoglycemia, when glucose 6-phosphatase cannot convert glucose 6-phosphate into glucose, glucose 6-phosphate starts getting into glycolysis. Because glucose 6-phosphate cannot form glucose, the excess glucose 6-phosphate gets into glycolysis. And what will you get as a result of glycolysis? You get pyruvate. And this pyruvate gets converted to lactate. And that causes lactic acidosis. Okay. Additionally, pyruvate also gets converted to acetyl-CoA. Didn't I keep telling you? Pyruvate in the presence of PDH complex gets converted to acetyl-CoA. And this acetyl-CoA will be used for fatty acid synthesis. All of you remember, the building block of fatty acid is acetyl-CoA. Yes. So this acetyl-CoA will be used for fatty acid and cholesterol synthesis. Excess fatty acid will be stored as triacylglycerol. And excess cholesterol will be stored as cholesterol ester. Do you remember the history says xanthomas? When will a child present with xanthoma? Only when there is hypercholesterolemia. Why is there hypercholesterolemia in von Gierke's? It is because glucose 6-phosphate gets into glycolysis, becomes pyruvate, gets converted to acetyl-CoA that is used for fatty acid and cholesterol synthesis. That will cause hypertriglyceridemia and hypercholesterolemia. And only because there is hypertriglyceridemia, the child will have doll-like faces. Have you all heard of this? Yeah, the child will have, what do you mean by doll-like faces? Chubby cheeks. Why do you find chubby cheeks? It is because triglyceride accumulates here. Okay, that's why it is doll-like faces. And the same reason, hypertriglyceridemia, excess cholesterol and excess TGL will accumulate in liver. That causes fatty liver and xanthomas. Okay. And why ketosis? Acetyl-CoA not always can get into fatty acid and cholesterol synthesis. Acetyl-CoA, when it cannot get into fatty acid and cholesterol synthesis, will condense to form ketone bodies. And that is why you find ketosis and you find lactic acidosis. So can you tell me what are the expected features of von Gierke's disease? I want all of you to answer this. Von Gierke's disease caused by a defect of glucose 6-phosphatase will principally present with hypoglycemia. That will be the presenting feature. And then when you collect blood sample and then when you observe the child, you will find multiple other features. What are the other features? Glucose gets converted to pyruvate. Pyruvate gets converted to acetyl-CoA. There is increased fatty acid and cholesterol synthesis. So there is hypertriglyceridemia and hypercholesterolemia. Hypertriglyceridemia is the reason for doll-like faces. Hypercholesterolemia is the reason for xanthomas. And when both TGL and cholesterol accumulate in liver, that causes fatty liver. And this fatty liver will cause hepatomegaly and renomegaly. Yeah, hepatomegaly and renomegaly are features. And not always acetyl-CoA can be used for fatty acid and cholesterol synthesis. So excess acetyl-CoA will form ketone bodies. So you find ketosis. And there is also lactic acidosis. Okay. So have you explained all the features here? Hypoglycemia is hepatomegaly because of triglyceride and cholesterol getting accumulated there. Lactic acidosis is because pyruvate becomes lactic acid. Ketosis is acetyl-CoA becomes ketosis. There are xanthomas on the buttocks. So everything has been explained. So what is your answer, all of you? Do you have any doubt now? It is glucose 6-phosphatase. It's an exact question which was asked not long back, June 2021. Which means you will FMGE June 2021, which means you have to anticipate such questions in future. Okay, so don't fall for just factual discussion. Yeah, don't just be happy about learning something factually. Try to understand and learn. Okay. So this is another question asked in June 2020. Complex 4 is inhibited by what? Yeah, the question is complex 4 is inhibited by what? Can anybody try answering this? Rotenone, malonate, BAL, cyanide. The answer is very good, lazy trip. The answer is cyanide. Yeah, the common poisons, good Rishnika. So cyanide, hydrogen sulfide, carbon monoxide. Common poisons like cyanide, hydrogen sulfide and carbon monoxide, they inhibit complex 4. Very good, lazy trip. Rotenone inhibits complex 1. I'm impressed. Good. And how about malonate? I'll be happy if any one of you can answer. Good, lazy trip. Yes. Didn't I tell you malonate inhibits succinate dehydrogenase? I told you, right? Malonate inhibits succinate dehydrogenase, which is nothing but complex 2 of electron transport chain. So rotenone inhibits complex 1, malonate inhibits complex 2, BAL. How many letters do you find in BAL? 3 letters. Yeah, BAL inhibits complex 3. Yeah, BAL inhibits complex 3. So let me tell you quickly about electron transport chain complexes and about inhibitors, because inhibitors are being often asked. So listen to this for another 5 minutes. In another 5 minutes, I will tell you how electron transport chain complexes are arranged and what do these inhibitors do at various levels. Okay. So first tell me in electron transport chain, how many complexes do you have? Electron transport chain has got 5 stationary complexes and 2 mobile complexes. Yeah, memorize it. Electron transport chain has got 5 stationary complexes and 2 mobile complexes. The 5 stationary complexes are named in Roman letter. Complex 1, 2, 3, 4 and 5. They are named in Roman letters. So what is complex 1? Complex 1 is nothing but NADH linked dehydrogenase. Complex 1 is nothing but NADH linked dehydrogenase, that is electrons from NADH will enter into electron transport chain through complex 1. What is complex 2? I have already told you, all of you please answer. What is complex 2? It is succinate dehydrogenase. What is complex 3? Complex 3 is cytochrome B. Yeah, complex 3 is cytochrome B and C1. What is complex 4? Complex 4 is cytochrome A and A3. Complex 4 is cytochrome A and A3. And finally, what is complex 5? Complex 5 is ATP synthase complex, which I won't be showing you in this presentation. Yeah, complex 5 is ATP synthase complex. So quickly tell me, complex 1 is NADH linked dehydrogenase. Complex 2 is succinate dehydrogenase. Complex 3 is cytochrome B and cytochrome C1. Complex 4 is cytochrome A and A3. And finally, complex 5 is ATP synthase complex. So these are the 5 stationary complexes. Now, what are the 2 mobile complexes? The 2 mobile complexes are number 1, Q. Yeah, Q, which is placed between 1 and 3. Can you see that here? Q placed between 1 and 3. The next one is cytochrome C, which is placed between 3 and 4. The next mobile complex is cytochrome C, which is placed between 3 and 4. So tell me, what are the 2 mobile complexes? One is ubiquinone or Q placed between 1 and 3. The other one is cytochrome C placed between 3 and 4. Okay. Now about direction of transport of electrons. If it is NADH electron, it gets into electron transport chain through complex 1. Yeah. From complex 1, electrons go to Q. Is it not logical? That is the one which is present next. So from 1, it goes to Q. From Q, it goes to 3. Yeah. From 3, it goes to C. From C to 4. From 4 to oxygen. So all of you tell me, which is the final acceptor of electron and electron transport chain? It is oxygen. Okay. Whereas if it is FADH2 linked dehydrogenase, if it's an FADH2 electron that enters into electron transport chain through complex 2. From 2, it goes to Q. Yeah, from 2, it goes to Q. And from here, it goes to 3, 3 to C, C to 4, 4 to oxygen. So this is the direction of transport of electron. Now about inhibitors. Okay. So inhibitor, which inhibits electron transport between 1 and Q. Electron transport between 1 and Q. Here it is inhibited by amobarbital. This is inhibited by amobarbital, pyrisidin A. Yeah, pyrisidin A and rotenone. How do we remember this? Amobarbital, pyrisidin A and rotenone. Can you tell me which is the first alphabet? The first alphabet is A, right? So don't you see that all these 3 names have got something to do with A? The first one, amobarbital, starts with A. The second one, pyrisidin A, ends with A. And the third one, rotenone. It is not vitamin A, but don't you think it sounds like vitamin A? Yeah, what is vitamin A? Retinol, retinal and retinoic acid. This is not vitamin A, just for remembrance. So what are the 3 inhibitors which inhibit electron transport between 1 and Q? Between 1 and Q is inhibited by amobarbital, pyrisidin A and rotenone. Okay. Now complex 2 or succinate dehydrogenase. Complex 2 or succinate dehydrogenase is inhibited by malonate. This we know already. Yeah, succinate dehydrogenase is inhibited by malonate. Now, electron transport between 2 and Q. Yeah, between 2 and Q is inhibited by TTFA and carboxyl. How do you remember it? 2 starts with the letter T. Right? 2 starts with the letter T. So, between 2 and Q is inhibited by T, TTFA and carboxyl. Okay. And electron transport between complex 3 and cytochrome C. Electron transport between 3 and cytochrome C is inhibited by BAL and antimycin. So how did I ask you to remember it? BAL has got 3 letters, right? Between 3 and C is inhibited by BAL and antimycin. And finally, electron transport between 4 and oxygen. Between 4 and oxygen is inhibited by hydrogen sulfide, cyanide and carbon monoxide. Electron transport between complex 4 and oxygen is inhibited by hydrogen sulfide, cyanide and carbon monoxide. Okay, so these are the inhibitors of electron transport chain. So between 1 and Q, everything in A is amobarbital, pyrisidin A and rotenone. Complex 2 or succinate dehydrogenase is inhibited by malonate. And then between 2 and Q, between 2 and Q is inhibited by 2 starts with the letter T. So it is TTFA and carboxyl. Between 3 and C is inhibited by BAL and antimycin. Between 4 and oxygen is inhibited by hydrogen sulfide, cyanide and carbon monoxide. Okay. So what is answer? Complex 4 is inhibited by what? Complex 4 is inhibited by cyanide. A 40-year-old man presented with sclera of eyes and pinna having black pigmentation. Okay. The color of the urine turns dark on standing. What is the probable cause? Another June 2020 question. So the urine turns dark on standing. In that case, can you call it as a black urine disease? All of you, if urine turns dark on standing, can you call it as very good? Yes, I'm happy. Dream, very good. Rishnika, excellent. So can we call it as black urine disease? Yes, right. And what is black urine disease? It is alkaptonuria. And alkapton means black. Okay. So what are the facts that you know about alkaptonuria? Alkaptonuria is an inborn error of metabolism. Listen to this carefully. I'm going to tell you about all inborn errors of amino acid metabolism now. How to make a diagnosis. So listen to this. Alkaptonuria is an inborn error of metabolism wherein the enzyme that is defective is homogentisate oxidase. So just think logically and tell me, when homogentisate oxidase is defective, what will accumulate in the circulation? When homogentisate oxidase is defective, what will accumulate in the circulation? Homogentisic acid. And when this homogentisic acid gets exposed to air, it gets oxidized. On oxidation, it gets converted to benzoquinone acetate. Homogentisic acid gets converted to benzoquinone acetate, which undergoes polymerization to form melanin-like fibrils. And these melanin-like fibrils accumulate in joints and cartilages. And that causes joint and cartilage destruction. And that is the reason for euchronosis. So all of you tell me, what will be the presenting feature of alkaptonuria? Nobody is going to come to a doctor just because the urine turns dark on standing. Yeah, why will a person come to you? Only when something is disturbing. So what will be the disturbing feature? Joints involvement. They come and complain of multiple intervertebral disc bulges or prolapses or multiple joints involvement, knee pain, ankle pain, elbow pain. So that is called as euchronosis, and the reason for euchronosis is accumulation of melanin in cartilages and bones of in the joints. Okay. And the melanin-like fibril also accumulates in skin and mucous membrane. When melanin accumulates in skin, yeah, that causes black pigmentation of pinna. The tip of the nose will be pigmented. Thenar and hypothenar eminences are pigmented. Okay, so thenar and hypothenar eminences are pigmented, pigmentation of pinna and nose. Okay, and it also accumulates in mucous membrane, it accumulates in sclera. So have you seen this image? Yeah, do you see a scleral pigmentation, a blackish pigmentation in the sclera, both along the attachment of medial rectus and lateral rectus? And this is called as Osler's sign. What is this called as? This is called as Osler's sign. This is scleral pigmentation. This is the first sign of alkaptonuria. Yeah, sign is something which you elicit. So what will you be able to see first? It is scleral pigmentation. What will be the first symptom? The first symptom will be urine turning dark on standing. Okay. And that is all about alkaptonuria. So what are the facts that you have learned about alkaptonuria? Alkapton means black. So it is black urine disease. The moment you see urine turns dark on standing, you're going to choose it as alkaptonuria. You should remember it is caused by a defect of homogentisate oxidase. Which is the first symptom? The first symptom will be urine turning dark on standing. The first sign will be scleral pigmentation, which is called as Osler's sign. Okay. Now to exclude other choices about phenylketonuria. Can anybody tell me what is phenylketonuria? Phenylketonuria is caused by a defect of phenylalanine hydroxylase. Don't we know that? For exclusion purpose and for you to know about other choices, I'm going to tell you about all the other choices. So phenylketonuria is caused by a defect of what? It is caused by a defect of phenylalanine hydroxylase. When this enzyme is defective, the child will present with mousy odor of urine. Phenylketonuria, the child will present with mousy odor of urine. How do we remember it? You can have this image in mind. Yeah, don't you know that mouse and keyboard go hand in hand? Yeah, mouse and keyboard go hand in hand. Mousy odor, ketonuria. Yeah, so mousy odor is a feature of phenylketonuria, and they also present with hypopigmentation. Why do they present with hypopigmentation? When phenylalanine hydroxylase is defective, phenylalanine cannot be converted to tyrosine. And without tyrosine, melanin cannot be synthesized. Without melanin, there will be hypopigmentation. Okay. So mousy odor, hypopigmentation, and mental retardation. Okay, and mental retardation. So tell me, what are the features of, see, as far as FMG is concerned, they don't ask you rare disorders. Yeah, they ask you common disorders. And common disorders, these days, they don't ask you factual questions. They give you a small history. They ask you to pick up the right answer. So you should be very clear about all the presenting features of these disorders. The moment you see mousy odor, you should pick up phenylketonuria. Key words are essential. So mousy odor, hypopigmentation, mental retardation. All these are features of phenylketonuria caused by a defect of phenylalanine hydroxylase enzyme. Okay. Now about maple syrup urine disease. So maple syrup urine disease is characterized by burnt sugar odor of urine. Yeah, maple syrup urine disease. Maple syrup is burnt sugar, right? So it smells like burnt sugar. So burnt sugar odor of urine, and it is caused by a defect of branch chain keto acid dehydrogenase enzyme. Yeah, it is caused by a defect of branch chain keto acid dehydrogenase enzyme. And in this condition, the child will present with ketosis. Yeah, the child will present with ketosis because it's a defect of branch chain keto acid dehydrogenase. So when that enzyme is defective, keto acids logically accumulate, right? So it will present with ketosis. Yes, and hypoglycemia. Hypoglycemia, ketosis, burnt sugar odor means it is caused by maple syrup urine disease caused by a defect of branch chain keto acid dehydrogenase enzyme. And all of you memorize this. This enzyme is dependent on thiamine. Branch chain keto acid dehydrogenase is dependent on thiamine. So this might be asked to you. Maple syrup urine disease patient will respond to which supplementation? They respond to thiamine supplementation. Okay. Now for completion's sake about Hartnupp's disease. What is Hartnupp's disease, all of you? Any word that you can remember about Hartnupp's disease? Dream or anyone else? Hartnupp's disease is tryptophan malabsorption. Yeah, Hartnupp's disease is nothing but tryptophan malabsorption, wherein the transporter that is responsible for absorbing tryptophan along the intestine goes wrong. So you're not able to absorb tryptophan along the intestine. And do you know that tryptophan is a precursor of niacin? All of you, do you know that tryptophan? If you don't know, please memorize it. Tryptophan is the precursor of niacin. So tryptophan malabsorption will cause niacin deficiency. And do you know niacin deficiency causes 3 Ds of pellagra? Niacin deficiency causes 3 Ds of pellagra. What are the 3 Ds? Diarrhea, dermatitis, and dementia. Yeah, diarrhea, dermatitis. When I say dermatitis, it is dermatitis in the photo exposed area, sun exposed area. For example, along the collar. Yeah, that gives it a characteristic name. What is the name? Castle's necklace. So why am I not seeing any answers from you all? All of you, please answer. Yeah, please be active in the chat box. So this image has been asked previously in FMG, right? Very good, Vishal. Excellent. Yeah, this has been previously asked in FMG, Castle's necklace. So why is it Castle's necklace? Because wherever it is exposed to sun, yeah, exposed to sun, you find features. So this is a feature of 3 Ds of pellagra. Pellagra is caused by niacin deficiency. Not only by niacin deficiency, because tryptophan is a precursor of niacin, even tryptophan deficiency can cause pellagra. And tryptophan malabsorption or Hartnupp's disease will cause the same. Okay. So answer here is alkaptonuria. Okay. So now tell me the answer of this. I have already told you. I want you to give me the right answer. A 4-month-old infant presents with complaints of refusal to suck breast milk. Further workup shows hypoglycemia, ketosis, the smell of burnt sugar. Even if you know nothing about any other features, all you can find the name of the disease. Yes. Burnt sugar, what is the answer? It is very good. Burnt sugar odor is maple syrup urine disease. And what is maple syrup urine disease due to? I told you it is caused by a defect of branch chain keto acid dehydrogenase enzyme. Now do you understand why I'm explaining all features and enzyme defects? Because they give you such tricky questions these days. So maple syrup urine disease is caused by a defect of branch chain keto acid dehydrogenase enzyme. And this responds to which vitamin supplementation, all of you? This responds to thiamine supplementation. Now, what is isovaleric-CoA dehydrogenase deficiency? Isovaleric-CoA dehydrogenase deficiency causes isovaleric acidemia. It causes isovaleric acidemia, and this is characterized by sweaty feet odor. Yeah, it is characterized by sweaty feet odor. How do you remember this? Yeah, from the beginning, I've been telling you so many facts about urine odor, right? Yeah, so can we start discussing about urine odor and how to make a diagnosis? Yeah, the first one is mousy odor. Can you all answer this? Mousy odor is a feature of which disorder? Phenylketonuria. And how did I ask you to remember? I asked you to remember this link, right? Yeah, mouse and keyboard. So mousy odor is characterized by, mousy odor is a feature of phenylketonuria. Okay. And then the next one is, yes. So the next one is fruity odor. Fruity odor is a feature of diabetic ketoacidosis. Okay, fruity odor is a feature of diabetic ketoacidosis. And then cabbage odor. Cabbage odor is a feature of type 1 tyrosinemia. Okay, cabbage odor is a feature of type 1 tyrosinemia. If you're asking me how do I remember it, have this image in mind. Okay, so have this image in mind. Do you see that here the tire has been repurposed? Do you see that tire has been repurposed to grow cabbage? So cabbage odor is a feature of type 1 tyrosinemia. This you can use to remember. Okay. And then the next one is boiled cabbage odor. Boiled cabbage odor is a feature of hypermethionemia. Okay, boiled cabbage odor is a feature of hypermethionemia. How do we remember it? I don't like the odor of cabbage. Yeah. So boiled cabbage is even worse. Boiled cabbage odor is even worse. It is too much to handle. Yeah. Boiled cabbage odor is too much to handle. Too much is hyper. So boiled cabbage odor is a feature of hypermethionemia. Okay. The next one is again something related to methionine, which is methionine malabsorption syndrome. The next one is methionine malabsorption syndrome. And this gives an odor which is oast house odor. Yeah, what is it? It is oast house odor or beer odor. So if you're asking me what is oast house, this is how the oast house looks. Okay, this is how an oast house looks. And in this oast house, we dry hops flour. In this oast house, we dry hops flour and then we use it as a flavoring agent for beer. So this is called as oast house odor, which is nothing but beer odor. So if you see beer odor in a child, that is called as beer baby syndrome or oast house syndrome. And beer baby syndrome or oast house syndrome is caused by methionine malabsorption. Do you all understand this? That is caused by methionine malabsorption syndrome. And the next one is swimming pool odor. Yeah, the next one is swimming pool odor. And that is a feature of Hawkinsinuria. Swimming pool odor is a feature of Hawkinsinuria. For remembering that, use this image. Yeah, use this image. Do you see that a hawk is flying above the swimming pool? Yeah, do you see that a hawk is flying above the swimming pool? So swimming pool odor is a feature of Hawkinsinuria. Clear? Okay, swimming pool odor is a feature of Hawkinsinuria. And then we know about burnt sugar odor. So tell me, what is burnt sugar odor? It is maple syrup urine disease. And then isovaleric acidemia. Didn't I tell you just now? Isovaleric acidemia is characterized by sweaty feet odor. Yeah, sweaty feet odor. To remember that, have this image in mind. Do you see two feet placed on ice? Yeah. So sweaty feet odor is a feature of isovaleric acidemia. Okay. So the last one is, as I told you, burnt sugar odor is a feature of maple syrup urine disease. Okay. So have you memorized all these odors and are you clear about these disorders? I hope it's clear to all of you. Yeah. So for mouse, what will you remember? For mouse, you remember mouse and keyboard. So key is ketonuria, phenylketonuria. Fruity odor, all of you know this. Fruity odor is a feature of diabetic ketoacidosis. Cabbage, remember the image which I showed you, wherein tire is repurposed to grow cabbage. So cabbage odor is a feature of type 1 tyrosinemia. Boiled cabbage, I said too much to handle, too much hyper. So boiled cabbage odor is a feature of hypermethionemia. Methionine malabsorption is Osthaus syndrome. Yeah, methionine malabsorption is Osthaus syndrome or beer baby syndrome. So the child will give an odor of beer. Yeah, tyrosinemia, thyre. Very good. And then Hawkinsinuria, remember swimming pool hawk. Okay, so swimming pool odor is a feature of Hawkinsinuria. Sweaty feet odor is a feature of isovaleric acidemia. Burnt sugar odor is a feature of maple syrup urine disease. Okay. Selenium acts as a cofactor for all except. This is also repeatedly asked. Selenium acts as a cofactor for all except. The answer is glutathione reductase. Yeah, the answer is glutathione reductase because selenium in the form of selenocysteine. Selenium in the form of selenocysteine is necessary for forming three enzymes. What are the three enzymes? Glutathione peroxidase, thioredoxin reductase, and 5' deiodinase. All of you should know this. Selenium in the form of selenocysteine is necessary for the activity of glutathione peroxidase, thioredoxin reductase, and 5' deiodinase. Now, what is that you should remember about glutathione reductase? This needs riboflavin. Glutathione reductase is dependent on vitamin B2 or riboflavin. So if you suspect B2 deficiency, if you suspect riboflavin deficiency, what will you estimate? You will estimate RBC glutathione reductase activity. If you're asking me how do I remember it, ribbon and glue. Yeah, ribbon and glue go hand in hand, right? If you're doing some artwork. If you are doing some artwork, ribbon and glue are essential. So riboflavin, glue, glutathione reductase. So if you suspect riboflavin deficiency, what will you ask for? RBC glutathione reductase activity. Clear? Now another question. This was asked both in June 2020 and June 2021. Xeroderma pigmentosa is caused by a defect of which repair? So DNA repair mechanism, Xeroderma pigmentosa is caused by a defect of which repair mechanism? Do you see an X here? It is caused by a defect of nucleotide excision repair. Yeah, Xeroderma pigmentosa is caused by a defect of nucleotide excision repair. So now I will tell you about the disorders caused by defects of repair mechanism quickly. First, I will tell you the 4 repair mechanisms. The first one is base excision repair. The first one is base excision repair. The next one is mismatch repair. The third one is nucleotide excision repair. And the last one is double-stranded DNA break repair. So first, all of you memorize this. What are the 4 repair mechanisms that we have? Base excision repair, mismatch repair, nucleotide excision repair, and double-stranded DNA break repair mechanism. So first, about mismatch repair. This mismatch repair happens only during replication. It is more commonly done during replication. And a defect of mismatch repair causes, in mismatch, do you see 2 M's? Mismatch, yeah, 2M. And mismatch repair defect causes CC. What is CC? Hereditary non-polyposis colon cancer. Do you understand this? Mismatch repair defect causes MM. It causes hereditary non-polyposis colon cancer. Okay. And then nucleotide excision repair defect. How did I ask you to remember it? Excision has got an X. So nucleotide excision repair defect causes X xeroderma pigmentosa. Okay. And double-stranded DNA break repair defect. Double-stranded DNA break repair defect causes ABF disorders. What is ABF disorder? A stands for ataxia telangiectasia. B stands for Bloom syndrome. F stands for Fanconi's anemia. Yeah, ataxia telangiectasia, Bloom syndrome, and Fanconi's anemia. So if you remember these names, I think that's more than enough for you. So what did I tell you? How did I ask you to remember all this? Tell me all answers now. Mismatch repair defect MM, 2 M's. Defect causes 2C. What is it? Hereditary non-polyposis colon cancer. Nucleotide excision repair X. Defect causes X xeroderma pigmentosa. Double-stranded DNA break repair defect causes ABF disease. What are ABF disorders? Ataxia telangiectasia, Bloom syndrome, and Fanconi's anemia. Okay. So with this, let me end the session for today evening. So tomorrow again at 5 o'clock from 5 till 6:30, I will help you recollect many facts which are essential for FMGE based on previous year questions and based on high yield facts and concepts. Okay. So see you tomorrow at 5 o'clock. And I would want you to revise all that has been discussed today, because for today's session to be effective, only if you revise it, you'll be able to recollect during the exam. Okay. So I will share the PDF. You download the PDF and read it. Okay. Yes, I will share it. Thank you all. See you.